So I want to discuss knee revision surgery. So what's the difference between a primary knee or an elective knee replacement and a knee revision surgery? So essentially with a revision, it means you're taking components out and putting new components in. So you can see here in this diagram on the left and the right, those are primary knee implants. You've got a femur component that kind of cups the end of the femur, a tibia component that sits on the top of the tibia, and then there's a piece of plastic that goes in between. On a revision, you can see it's a lot more metal. You've got metallic stems that attach to the femur component. You've got metallic stems that connect to the tibia component. And then you've also got these augments right in here that make up for bone loss. Because when we remove the implants, you always lose a little bit of bone. You had bone resected when you had your original knee replacement, and then in order to get rid of the implant, you lose a little bit of bone along with the cement. Also, a lot of times, the reason we're doing the revision surgery is because you've already lost bone. One of the implants is loose and has started to subside or shift and kind of wear away the bone, or there's been a fracture, there's been a problem. Sometimes, as the plastic starts to wear, you get what's called osteolysis, which is like where the bone turns into Swiss cheese. You get little holes in it, and that means we have to get back into good healthy bone and replace that bone with metal pieces. So there's all sorts of bony defects you can have, and once you remove the implant, that's where you see what those defects are. And sometimes they're not too bad, and other times they're severe, where you're going to have to make it up with a lot of metal. And there's kind of a scale from little to big. So if we look at all these augments, here's our femur. That's the end of the bone here. It's kind of upside down. But there's augments distally that fit here, and there's augments posteriorly, and those just match the bone that you've resected in order to get down to healthy bone. Here's another look at it looking into the femur component. On our tibia, there's augments that can go on either side. Then they come in different, all these augments come in different sizes. 5, 10, 15 millimeters. They don't come in 1 millimeter increments, they come in 5 millimeter increments, so the sizes are pretty limited. When we look here, these are real femur components. This is a femur component here, and those green augments right there, those are trial augments. That's what we put on when we're testing the revision knee to see if it's going to work. And if it does, we open up the real ones, and they're sterilely packaged individually. This right here is a look at a real augment. This is on the distal femur, and it actually gets screwed into the component. So when it fits onto the bone, it fits like this, where that augment sits flush with where you cut the bone, and that gets cemented on. It kind of looks like this. This femur is sliding onto the bone. You've got your cut here and your cut here, and it's going to sit flush once we're all done. The tibia works similarly. There are augments. This is a 10 millimeter augment. It's only on half of the tibia. This is a 5 millimeter augment that's on the full thing. So it makes that base plate thicker. It makes up for that loss of bone. In addition to the augments, we also need to talk about fixation, because once you start losing bone, the bone isn't quite as good. And we end up needing to talk about zone fixation. So a primary knee replacement has fixation up in zone 1, right at where your cut is. And that almost by itself is enough fixation. But on a primary knee, you also get a small stem on the tibia, and that gets into zone 2, which is called the metaphysis of the bone. Zone 3 is where you get down into the diaphysis, or the shaft of the bone, in both the tibia and the femur. And in order to gain fixation, there's two different constructs we use. One of them is called a cone. They're these shaped constructs, and those actually fit right here into the metaphysis. And the other construct are stems. And so we add these stems onto the implant so that it goes down into zone 3, and you get fixation down into good bone, because the zone 1 bone is no longer any good. Once you've had that primary knee replacement, you take that implant out, that zone 1 is not enough fixation. That implant won't last. We have to get down into zone 2 and zone 3 to get a knee that's going to last 20 years, what we expect. So what's our final construct look like? It looks like this. We've got the femur component, we've got the tibia component, and this is looking at it head on, this is looking at the side, and you can see all this extra metal here and here, those are augments used. And you can see the tibia here, it almost looks like there's two levels here and here. That's because there's a tibial augment on there. And then this big structure right here is a cone that was utilized. The stem itself is cemented, so all that kind of fuzzy cloud looking, that's cement that's helping to bind this all in. So this is a fully cemented revision total knee. The bone defects get made up with metallic augments, and we get fixation into good healthy bone in zone 2 and zone 3 with the stem and the cones. And that is how a knee revision works. That's what makes the implant different, and that's the reason that the implant is different between a primary and a revision knee replacement. So I'd like to discuss why knee revisions are necessary. What happens to a replaced knee that leads it to needing to be revised? So we have on the left here, this is an AP or a frontal view and a lateral or a side view of a knee that was replaced about 20 years ago. And actually the cement that bonds the implant to the bone looks great. There's really no sign that the implants have become loose, but what has happened is the plastic shim in between the bones has just worn out. And over time, constant knee bending and straightening, that will wear away the plastic little by little, that friction. And so over 20 years, that plastic has worn down and has led to some laxity in the knee. Because there's more space in there, the knee kind of rattles a little bit. But the implants are still well fixed, and it's a symmetric laxity, which means when the knee is straight and when the knee is bent, there's the same amount of laxity because the plastic is just worn. So what we can do is do a mini revision on this type of surgery, and we end up here with our post-operative x-ray. You can see the space between the femur and the tibia is much greater now on both the front view and the side view, and when we compare it where the femur has kind of fallen back a little bit and worn out the back of the plastic here, now it's sitting right on top of the tibia where it's supposed to be, back in anatomic position, and that's a mini revision. We're not cutting out bone, we're not ripping the implants out, we're just removing the plastic insert, which can come out without really any trauma, and we're putting a new one in. And this is a much smaller type of a revision. This is like a mini revision. The next thing I want to look at is a more extreme revision, and this is for implant loosening. You can see this implant here. I mean, it is wildly crooked, and it wasn't put in like that. It got loose over years. The cement mantle wore out, and the implant started to erode the bone and become crooked. If you get something called a bone scan, which is this here, it will show that it's loose. Now, you don't need a bone scan on something quite this obvious, but sometimes on the real x-ray, it's not quite as pronounced as it is here. Now, a bone scan is different than a bone density scan. A bone density scan looks to see if you may have osteoporosis. This is completely different. This is some dye that's injected into your vein, and then we see how much of that dye goes to the knee. So on this side, we have a normal knee. This knee had already been replaced as well. And there's a little bit of uptake, a little bit of dye, that dark area, but that's a normal amount of dye that you expect. This right here is abnormal. All those dark spots here, and even around the kneecap, this implant had become grossly loose and needed to be revised. And that's what the bone scan will tell us. Another reason implants may need to be revised is instability. Now you can see on this x-ray, this is a pretty extreme example of this. The femur is actually dislocated anteriorly. This knee was so loose and so unstable that it was actually dislocating. This kind of thing is incredibly rare. Yes, it happens, but it's very rare. In order for something like this to happen, the knee has to go in improperly, or there has to be a lot of wear over years and years and years, or potentially an injury that tears a ligament. With something this much instability, just taking out the piece of plastic and putting a thicker one in is not going to be sufficient, and this is going to require a big revision. Sometimes the instability is more subtle, And when we talk about instability, we talk about instability when the knee is pulled straight and when the knee is bent, all right? And if it's symmetric instability here and here, like when the plastic is worn out a little bit, you do that little plastic exchange, that mini revision. But most times what it is when the knee is bent, it's much more unstable. We call that flexion instability. And bad flexion instability leads to the knee, dislocating or nearly dislocating, and it is very painful. If you think about it, as humans, most of the times we're using our knee, it's bent. Stairs, even walking, any sort of athletic activity, anything you're going to do that involves moving is with the knee bent. We don't walk with straight knees. And so when you have instability and flexion, it's detrimental to any sort of movement and causes pain. Another reason that we end up having to revise knees is infection. Now, this is incredibly rare as sterile technique has gotten better, but it still happens. And you can have an infection right after surgery, and that's the most common. It's super rare, but it can happen. There's certain things that, increase the likelihood of infection, such as a lot of medical comorbidities, like diabetes, heart disease, also diabetes, and not taking care of the wound. It can be something where bacteria gets in the knee at the time of surgery, or it can be something where you're not taking care of the wound and bacteria gets into the wound and then goes deep. These can also happen, these infections, years later, decades later. You brush your teeth at night, bacteria get in the bloodstream. Now that is a very rare occurrence, and usually it can be tracked to something, a little bit worse. You get, appendicitis or an infection in your belly, and that infection happens to spread to the knee. You get a big cut that gets infected on your leg and that spreads to your knee. You're diabetic, you get a toe wound, that spreads to the knee. It tends to be a more obvious source such as that rather than just simply brushing your teeth. That's not a never happens, but it's a nearly never. So when you get an infection in your knee, it requires typically 2 surgeries. If you catch it right away within the first few days of the week, you can do that mini revision. Take out the piece of plastic, put a new one in. But after that, what happens is the bacteria will actually stick to the implant and form this glycocalyx, which is like a cell wall membrane that the bacteria hide behind, and you can't wash it off, and and antibiotics can't penetrate it. So what you have to do is actually remove the metallic implants. So in this knee, the previous implants were removed, and this is basically an antibiotic spacer held together with a bunch of antibiotic cement, and it's just designed to elute antibiotics and give off antibiotics, and that way it will help eradicate the infection. You get 6 weeks of antibiotics through a special IV, and then once you're off of all the antibiotics and we know that we feel confident that the infection has passed, you come back in and put the definitive revision knee back in. Another reason for revision knee is component malpositioning. So if we look up here at this knee, the top 3 x-rays, we have an AP frontal view, a lateral side view, and what we call a sunrise view to look at the patella. And so these implants, you think they're just pointed straight at you, but there's actually subtle differences. The tibia needs to be slightly externally rotated, and so does the femur. And this slight rotations, matter of just 2 or 3 degrees, can change the way the patella tracks within the femur. And so we see on this sunrise view here, that's the trochlear groove right here. That's the groove where this kneecap glides as the knee bends and straightens. And this one is perfectly situated within that groove. That's because the tibia is rotated appropriately, the femur is rotated appropriately, and the patella was well done. And so this knee, mechanically, is functioning quite well. If we look down here at this x-ray, on the front view, it looks okay. On the side view, it looks okay. You can't tell. But when we look at this sunrise view, the patella has fallen off. And why? Because the implants were not put in the correct position. They were mal-rotated. It's very, very subtle. Sometimes we can have to get a CT scan of the entire femur and the entire tibia in order to be able to see where these implants are rotated, take those measurements, and figure out if component malpositioning is what's causing the patella to maltrack. This is obviously an extreme example. I mean, you can see that patella is completely off, but sometimes it's just a little more tilted, and going back in to put those components in the right position is going to be helpful. Now, obviously, these are all highly complex situations, and that's why having robotic technology, which can help change the rotation of the implant and change the amount of bone you take by 1/2 degree and 1/2 millimeter, is so paramount. It's a much more precise way of doing this surgery, and we'll see in the next video how exactly we accomplish this. So now I want to talk about robotic revision specifically, and why when I switched over, it's become a game changer in terms of the surgical flow as well as the outcome for my patients. So if you look here at these two pictures, this is a standard surgical setup for a revision total knee. There are countless numbers of pans. I mean, 1, 2, 3, 4, 5, 6, 7, 8, 9, and all of those, plus all of this equipment up here. That's a standard setup. And this is A, extremely expensive, B, extremely time consuming to set all this up, and 3, incredibly cumbersome. As you're going through the surgery, we have to flip through all these pans, move them to uncover another one, and then dig through. It makes it very, very cumbersome, and significantly slows down the surgery. And when I talk about slowing down surgery, it's not a desire to get done faster, but we know in the knee and hip replacement world, for every 15-minute increase in surgical time, it significantly increases your risk of infection. So if we have that wound open 15 more minutes, that is going to be a higher risk for infection for that patient. Here, we have everything I need open for a robotic knee revision. We're talking about 4 different pans. It's less than 1/4 of what we have to open for a standard knee revision. It's much less fumbling for the entire surgical team, and it's much more efficient and elegant, and it certainly leads to better outcomes. So, stark difference between this right here and all of this here. When we get a knee like this, we know we're going to end up with some bone loss, right? This implant has fallen down, it's worn away all of this bone in here, and we're going to end up with something here, probably not as bad as this, but somewhere in the 2 to 3 range. What we're going to try to do is create a flexion and extension gap that are equal. And what I mean by that is extension when the knee is straight and flexion when the knee is bent. It should be a rectangle. And it should be a rectangle as you look at it from the side, or what we call a sagittal view, and the rectangle is in blue. And it should be a rectangle when you look from the front, or what we call a coronal view. If it's not an equal rectangle, what you end up with is something like this red box. You end up with a trapezoid. And that's because the MCL over here is either a little bit lax, or there's more bone missing on the medial side. So recreating these boxes is paramount to achieving the optimum outcome in a knee revision. Now, in a primary knee, the same holds true. You want to create equal extension and flexion space, but it's much easier when you don't have all of the bone loss and you don't potentially have damage to the ligaments and stretched out ligaments. In revisions, this is much more challenging to achieve. So I want to show you this video here, and this is all about articular planning. This is what's so cool about a robotic knee revision, all right? So, what we do is we take the knee when it's straight and when it's bent, and we test the ligaments, all right? So, if we look here, and we look back here, when the knee is straight like this, that's when the knee is in extension. It's showing an orange bar and a purple bar. The orange bar is your MCL, all right? That's the ligament on the inside of the knee. The L is the LCL, or the lateral side, and that's your ligament on the outside of the knee. And so this knee right here is very, very tight because the 0 line here, it's tight when the knee is straight, and it's really loose when the knee is bent. This is actually a knee that was dislocating, all right? It was so unstable in flexion, the knee was actually popping out and dislocating, and you can see that here. Well, on x-ray, you can see that it's happening, but we can actually measure in millimeters, 1, 2, 3, 4, 5, 6, the difference in the gaps, because this bar over here is the extension gap. This bar over here is the flexion gap. And the fact that the bars aren't equal is because it looks more like this, a trapezoid. So the trapezoid is much bigger in flexion than it is in extension. Now, as we go to the robot planning screen, what this does is this shows the size of the femur, size 6, the size of the tibia, and the thickness of the plastic insert that we're putting in. It also shows your range of motion, right? So this knee had good range of motion from 2 degrees all the way to 130 degrees. And in alignment beforehand, it was only in 1 degrees of varus, which means it was relatively a straight knee. What we're going to do now is change the components, change the size, their orientation to help balance this. And you'll see that I want these bars to drop down, this bar to come up, and we want fairly symmetrical boxes. Now, you don't actually want perfectly symmetrical, and the reason is that's not how a native knee works. The native knee, the medial side, the orange bar, should be slightly tighter than the purple bar. Now, with standard instrumentation, we're just trying to make actual equal boxes. But with robotics, we can actually recreate normal kinematics, the normal function of a knee. So watch what I do here. As I start changing the implant, I'd make the femur size bigger. I take some distal femur, I take the bone. I start changing the orientation, changing the rotation to help balance it. And as I do this, you see the bars getting slightly closer together. Now, this is a little bit above what I can just explain in a few minutes. This is what takes, all those years of training. But we end up here with a perfectly balanced knee, in my opinion. Our gaps on the lateral side, 1.6, pretty much the same as in flexion, 1.7. And then on the inside, 0.5 millimeters and 0 millimeters. So those are really, really close. The orange bar, the medial side, is tighter. It's 0 here and 0.5 than the lateral side. And that's perfect. That's exactly what I'm aiming for. So we have tested the ligaments. Now we have created what we call a theoretical joint line. This is where we want our components to sit. And now we go in and remove our implants. And once the implants are removed, we're going to find out where our bone defects are. And our bone defects are what we're going to have to fill with the augments so that we can actually recreate this theoretical joint line and make it our actual joint line. So next, let's look at the bone defects. So what we're going to do is take the robotic burr and just take it over the bone. And anything that's red is where we're missing bone. And not only does it show us that it's red, but we can actually measure in millimeters how big that defect is. And so you'll see, once I kind of map it all, I'll take the probe and measure in millimeters how deep it is. And that gives me an idea of what size augment I have. And then if we have 7 millimeters of bone missing, but we only have 5, 10, and 15 millimeter augments, what I can do is resect 3 more millimeters. Now you add the 7 millimeters that was missing to the 3 millimeters that we resected. That gives us 10, and now I can add a 10 millimeter augment on there and perfectly balance the knee. And that's what we're able to do with the robot. And so once I know what our defects are, the next thing we're going to do is plan for the augments, all right? So what we're going to see here, I've highlighted it for you. This is an extension, all right? So when the knee is straight, what I'm going to plan to do is resect more distal femur. So I'm going to move the femur, as we resect more bone, I'm going to move the femur more proximally to resect a little bit more bone to make for the augments, because I know I'm actually missing bone here. So what we do is shift it, and we shift it by five clicks here, okay? And that's for a 5 millimeter augment. Now, if I want to go to a 10 millimeter augment, then we shift it all the way up to 12, right? And then we come back to home base, right? We come back to that theoretical joint line. So once I have planned it, Once we have planned it, we resect the amount of bone to make for the augment. Then you go and you actually remove the bone. Then you come back to this screen and go back to home base. Now I'm going to show you how we do the posterior augments, or the augments in the back of the knee. It's the same thing. We shift the implant up, and then we go in and we remove that bone. And if we need a 5 millimeter or a 10 millimeter, and then we come back to home base. So by shifting the implant, we can tell it we need a 5 or 10 or 15 millimeter augment. Now, if we're going to do the tibia, we shift the tibia down, and that changes both extension and inflection, and we resect the bone. Then we come back to home base. So after every step, you have this theoretical joint line, you resect a little bit of bone, come back to home base. Then we go to the posterior femur, resect a little bone, come back to home base. Then go to the tibia, resect the tibia bone, then come back to home base. We want to end up back at home base so we know what we're trying to achieve. Then the next thing is, let's look at the additional bone removal, all right? So this is kind of combining this step right here with actually removing the bone for the augments. And so what I'm going to do is remove some bone here, and then you see that red I don't like. So I'm going to go back to the planning screen, cut 5 more millimeters, then come back, and now it's perfectly white. That's healthy bone. We just added another 5 millimeter augment. So now we're going to come back to home base, and we're going to shift it up, shift the implant anterior to resect some posterior femur to make the augments for that. And so you can see here, we end up with good bone on this side, that white bone. That looks great. So a 5 millimeter augment is going to be perfect. On this side, no, it's still red. That's not going to be enough. So we will actually come back later and resect 5 more millimeters. Now on the tibia, we'll do the same thing. We resect the tibia, and that's a nice white bone area. There's always a little defect in the middle. That's okay. But that's going to be perfect right there. And that's what we're trying to achieve. You want to be able to resect the exact amount of bone so that the augments fit your theoretical joint line. Because if you just resect down to healthy bone like a standard revision and then add augments on, you're not going to end up with a perfectly balanced knee. You're going to be off a little bit. And that's why this is so much more accurate. So to wrap it all together, this is showing the implant trialing. So this is after we've resected the bone. We've got our augments on our trial implants, and now we put the tibia component in. This is, again, just the trial. These are not the real implants. This is just one final step before we actually open the real implants. Make a little hole for the stem to go in. We put the implant in, and then we put the trial piece of plastic in. And when we do this, now I'll go and test it. And I'll test it both with it straight, and I'll test it when it's flexed up. And we'll make sure that it has the appropriate balance that we want. And this is exactly what we're looking for. So aim small, miss small. So we test the knee, we test the ligaments, then we remove the implants, then we look at the bone defects, then we resect the amount of bone we need to resect so that the plan will fit within the augments that we have. We're limited. We only have 5, 10, 15 millimeter augments. So we have to be able to remove an appropriate amount of bone to utilize those augments. And then we prove that we did what we set out to do. We trial it and make sure it works. And then finally, once we get to this step, we open the real implants and we actually put the knee in for you. And that's what makes a robotic knee revision so much more accurate and leads to better patient outcomes. Thank you.